And I welcome all of you in this seventh session of IAP NRC General Review Club. And today with us our chairperson, Dr. Rawat sir, after our EB member like Kasi Bhandaru, Santanu Dev sir. I also welcome our national coordinator, Dr. Indu ma'am, and national expert, Dr. Joseph sir. Today with us, our session expert, Dr. T.U. Sukumaran sir. Sir is a very known figure. Sir needs no introduction. Sir is at present professor and senior consultant in Caritas Hospital, Kottayam, Kerala. And sir was also national president IAP 2011. And our session mentor is Dr. Anil Sachdev sir. Sir is also well-known figure. Sir is at present HOD Department of Pediatrics and Director Pediatric Emergency Critical Care and Pulmonology Allergy in Gangsar Gangaram Hospital, Delhi. And our presenter is Dr. Antar Patel. He is Pediatric Pulmonology Fellow working in Gangaram Hospital, Delhi. So the article will be presented by the Gangaram Hospital, and presenter is Dr. Antar Patel, and mentor is Dr. Anil Sachdev sir. With this this brief introduction, now I am handing over the session to our national coordinator, Dr. Indu Khosla ma'am, to carry forward the session. Madam, please.
Yeah, thank you, Dr. Ajay, and thank you, Dr. Rawat and NRC for this beautiful platform of discussing the Journal Club articles. I must say, under the guidance of Dr. Matthews, we have become very wise, and we are not really taking each and every article by what it is saying, and we're really diving deep to derive more meaningful, inferences. And I think that's helping not only us but our students who are now become experts in analyzing an article. So without much ado, I invite the team from Gangaram Hospital, Dr. Antara, to start his presentation. Thank you very much. Please go ahead. The format would be in such a way that after he presents, then we will discuss the article, take the questions from the chat box. Post that, we will have expert comments from Dr. Matthews and any other person who wishes to comment on this. And then we will have the final word from Dr. Anil Sachdeva, and before we wind it up. Over to you, Dr. Andrew.
Thank you, ma'am. Good evening, respected seniors and colleagues. Today I will be discussing about one interesting review article. So I'll start sharing my screen. I hope I am visible. My screen is visible and I am audible.
Yes, you are visible and audible. Please carry on.
Good evening, everyone. So today we'll be discussing about Lancet Respiratory Medicine June 24 article. Title is Efficacy of Oral Corticosteroid for Acute Preschool Wheeze. So I'll be discussing in three phases. First phase, I'll tell a little bit about systemic review, individual participant, meta-analysis. Then I'll try to review the article, and then I'll assess the methodology of the article by ENSTAR method. I'm not able to move. Okay. So in evidence-based medicine, it has got three components.
Can you make your voice a bit loud? You are not audible very much.
Okay, once. Now is it better?
Oh, better now, better now. Okay, Enda.
Yes. So in clinical practice of evidence-based medicine, there are mainly three pillars. There should be a patient and stakeholder values. We should use our clinical skill using the best available medicine. But we should not take any evidence just based on the p-values. We should avoid cherry picking the results. We should always see about conflict of interest, and we should try to localize the low-powered studies. So in this hierarchy of evidence-based medicine, systemic review has got the highest importance. Systemic review, it is a scientific method for answering a focused questions. There are structure and predefined questions, and there are comprehensive research methodology attached to the identification of the answer. while the meta-analysis is the statistical part of the systemic review, where different statistical methods are used to answer the question. In the process of systemic review and meta-analysis, how it is formed, first we formulate PICO question, then it get registered. There will be a preformed structure of search. After searching, we will select and screen the studies, then we'll extract the data, assess for the biases, perform the synthesis, and then report is formed. So here there is something called individual participant data meta-analysis. How it is different from the routine meta-analysis. Here, raw data from each participant is included in the study rather than just going by the aggregate statistics. So what is the advantage? It reanalyzes and using the uniform statistical methods. So main goal is for precision, transparency, and flexibility. In traditional meta-analysis, only aggregate statistics are used. So advantage is it's patient level, covariate adjustment can be done. There can be harmonized samples, and there is improved reliability of the evidence. But there are a few disadvantages also, as it needs a lot of resources. The data will be quite variable. It is a complex analysis, and it needs a lot of cooperation from the other research authors. So this article's title is Efficacy of Oral Corticosteroid for Preschool V's, with the subtitle of a Systemic Review and Individual Participant Data Analysis. It's a PRISMA 2020 compliance study. They have extensively done PRISMA analysis, and they have reported it in a supplement, and trial was registered as well. So what is the clinical background? Why they had to need, what was the need to do this study? If you see the epidemiology, 1 out of 3 children under the age of 3 years and 1 out of 6 children under the age of 6 years are affected by preschool wheezing. It's often triggered by viral infection. It is one of the causes for hospital admissions. But there is a lot of clinical uncertainty, like this may be episodic or maybe persistent. There is a lot of diagnostic overlaps with bronchitis, early asthma. And there is a lot of clinical gaps as well, because there is a lot of heterogeneity in phenotypes. And the guidelines are also showing conflicting recommendations. If we see the global scenario for oral corticosteroid use, UK use around 12% of ED patients with corticosteroids, while US, the ED or inpatient, they use around 81% of patients with acute preschool V's corticosteroids. There is a lot of guideline discrepancy. National and institutional policies are variable. There is no uniform clinical algorithm. Clinical consequences are also, there is no consensus for the use of corticosteroid in preschool wheezers. So this justifies our systemic, this justifies the study. So when they conducted the study, these were the national guidelines available for the review. So each guideline was based on either hospitalization or severe exacerbation. Only few studies had mild or moderate. So there is a lot of heterogeneity in the guidelines for the use of oral corticosteroid in acute preschool wheezing. With this background, they have formed the study question. So the question was to determine the efficacy of oral corticosteroid when treating acute wheezing in preschool children. So age group, they had taken 12 years to 71 months, because they have omitted less than 12 months because there is a lot of bronchiolitis incidents are higher, and there is a strong evidence that there is no role of steroids in bronchiolitis. So that is why they have avoided this age group. What is the efficacy of oral corticosteroid in preschool wheezing? Which baseline characteristics or clinical predictor modifies the effective of oral corticosteroid? These are the study questions. Then PICO question for the eligibility criteria, that already we discussed. The age group presenting with acute wheeze, it's a clinical diagnosis. Accelerate if unavailable or out of the range age group studies. Intervention, they just try to see oral corticosteroids versus placebo. Outcome, primary and secondary, I will be discussing in the later subsequent slides. They have just taken randomized control trial, and rest of the studies they have omitted. how they have identified studies that was based on the extensive data search. They have searched online platforms. They have searched trial registry, and they have also taken the gray literature and conference proceedings. That means the literature that has not been published in an index journal, that also they have tried to search. Search period was 1st January 1994 to 30th June 2020. So deduplication was done using the software, and there were two independent reviewers, like authors only. They had reviewed and they have done deduplication so that there is no duplication of studies in the analysis. And there was no language restriction, so it's quite extensive data sourcing. So this is their Prisma flow diagrams. They have identified around 16,102 records. 12 studies were included in the final synthesis. But out of 12 studies, only 7 studies, they got the IPD, individual patient details they got. For the 5 studies, they just use aggregate data. Data acquisition and integrity checks, they have again included 12 RCTs, 7 with full databases. And integrity verification was done based on baseline characteristics, and outcome was compared to the original publications. Outcome measure, they had mainly primary and secondary outcome. Primary outcome was with severity score at 4 hours and 12 hours after oral corticosteroid administration. Secondary outcomes were length of hospital stay, revisits to the OPD or emergency department, rehospitalization, time back to normal, dose of SABA usage during the 7 to 14 days after onset of wheezing, need for additional steroids or any adverse events. So for severity of wheezing, there are multiple tools used in different studies. So they took the PREM as the anchor measure, and they try to compare the other studies, and then it was included in the final analysis. So these different studies has used prednisolone as the oral corticosteroids, but those were variable, 1 to 2 mg. Duration was 3 to 5 days among the different studies. If you see statistical methodologies, they have used 2 model method, stage 1 and stage 2 analysis. They have adjusted for covariables, and they have also measured heterogeneity. In IPD meta-analysis, they have used multiple covariables and clinical predictors like allergy history, family and parental factors, breastfeeding history, family size or number of siblings, exposure to animals, and gender, prematurity, etc. For clinical predictors, they had asked for past medical history, or any baseline wheezing severity if available. How they handle the missing data? Some trial lack the viral data or other baseline characteristics, which they have used for subgroup analysis or secondary objectives. So they have tried to use multiple imputation using chain question to compensate for the missing data. So what is the 2-stage approach? First stage is analyzing each study separately and then combining the results. In this method, they have used 2 logistic regression models. One is logistic regression for binary data, and another is linear regression for continuous data. And stage 2, all the results are combined, and then they have used random effect meta-analysis method to get the estimate. And these estimates are plotted over the forest plot. For heterogeneity, mainly it is in wheeze severity scoring that was observed in data that they have tried to rectify using the restricted maximum likelihood ratio. Retrace heterogeneity in the treatment effect was assessed by using Cochrane Q test, tau square test, and I square statistical test. That results are also available in the supplement tables. For the sensitivity analysis, that is done for common effect models, regression models, and study designs. So if we exclude the high risk of bias trials, then what is the outcome? If we exclude trial without IPD, what is the outcome? If covariables are not adjusted or there is fixed effect or some specific settings are excluded, what is the outcome? That is called sensitivity analysis. That has also been done in this study. Now comes the risk of bias analysis. That was done using Cochrane risk of bias tool for RCT. There were majority trials were low risk, but there were few studies which were high risk as well. I will be discussing in the subsequent slides. So if we see the risk of bias in individual study at IPT meta-analysis, there is only one study which has got high risk of bias. But if we see the ROB at the studies level, there are multiple studies at higher risk of bias. What is the implication that we'll be discussing in subsequent slides? Now we start discussing the results. These are the basic IPT trials that were included. That is the basic demography of the trial. Then the primary outcome with severity score at 4 hours, it was statistically significant, though mean difference was just minus 0.31 only, but it was statistically significant and there was no heterogeneity. So OCS modestly reduces symptom severity at 4 hours, which was statistically significant. And this was the forest plot for this one. This is the no effect line. Our diamond is on the right side of the no effect line. So it is statistically significant. Now, another primary outcome, that is with severity score at 12 hours, that was not statistically significant, and it doesn't help in symptom resolution. So it may tell that there might be a natural symptom resolution if we give or if we don't give steroids in these patients. So this is the forest plot for that. This diamond is crossing the no effect line. Key secondary outcome that has got positive significance, like oral corticosteroid significantly reduces the hospital stay with the mean difference of 3 hours and 18 minutes. The effect was greater in children with the history of wheeze and asthma. It was approximately around 5 hours in decrease of length of stay. This helps in meaningful operations and economic implications. This is again forest plot. This has got a nice diamond with a good confidence interval. Other secondary outcomes they have tried to see is long-term outcomes like revisit rates, rehospitalization, need for steroids, which has not got any significant p-value. There was significant reduction in short-term, short-acting beta-2 agonist at 14 days. So 4.75 less doses were required. But this was noticed only across the 2 studies, and recruitment of this sample was done from the single site. So it makes very low quality evidence. So we cannot recommend on the basis of this p-value. This I'll be discussing in the grade analysis. Adverse event, vomiting was the most common adverse event in the corticosteroid group, but there was no serious adverse event was reported, as this was a short-term steroid regimen. So this report suggests short-term benefit with minimal evidence for long-term outcome improvement. Subgroup analysis and sensitivity analysis, they have done extensively. Children with moderate to severe wheeze and prior wheeze or asthma benefited the most in subgroup analysis. Those with mild symptoms had no significant benefit and a higher risk of vomiting. Sensitivity analysis reinforced the findings and heterogeneity remains low across the outcome. So this is the grade analysis, grading of recommendation, assessment, development, and evaluation. So by just going through a p-value, we cannot recommend and we cannot take the study on a face value. We have to do grade analysis. Here, change of wheezing score at 4 hours was just moderate grade, while though there was no effect on 12 hours wheeze severity score, but it was a high grade evidence. Length of hospital stay, which is a positive outcome from this study, it has got high grade evidence. Remaining this last 3-1, time back to normal dose of SABA and on follow-up is a very low grade evidence. So implications from for the clinical practice. This finding supports the corticosteroid use for acute preschool wheeze in specific high-risk group, such as children with previous wheeze or asthma, presenting with moderate to severe wheeze. In low-risk children or first episode of wheeze, corticosteroid corticosteroids offer no clear benefit and may cause unnecessary side effects. This report supports risk-stratified corticosteroid prescribing, aligning with the conservative national guidelines over the broad GINA recommendation. If we see GINA 2025 also, in acute asthma, less than 5 years, for all severity category, they recommend use of oral corticosteroids. So strength of the study, it used the IPD analysis, standardized outcome metrics, low overall risk of bias, robust statistical methods, and they have got some clinical relevance. But there are a lot of limitations as well. Incomplete IPD coverage, 7 only studies had given IPD details, 5 studies details were missing. There was heterogeneity in clinical scoring. There were no long-term outcomes. Adverse effects were underreported, and there was no funnel plot was used. So there is publication bias. But if the study numbers are less, it can be avoided. So it's just a methodological gap, but not the limitation of the study. Funding they have discussed, but the funding of the study included for IPD that they have not disclosed. So now we'll try to assess the quality of methodology. So currently we have 3 methods to analyze IPD meta-analysis. For other meta-analysis, MSTAR2, a measurement tool to assess systemic review. It was published in 2017 BMJ. Tyree et al., it was published in 2015, and Wang et al., that is 2021. MSTAR does not discuss about IPD meta-analysis, while other two does discuss about the IPD meta-analysis quality of methodology. MSTAR has 16 items, while Wang 2 has 24 items and 5 domains. So but MSTAR is widely used, so we'll be using that method only for critical analysis of the methodology. These are the critical domains that has to be yes to get a good quality of evidence. So the item number 2, 4, 7, 9, 11, 13, and 15. What are these items? We'll be discussing in subsequent slides. First, did the research question and inclusion criteria include PICO component? Yes, already we have discussed. So this fulfills that criteria. Second was, did the report of the review contain an explicit statement that the review methods were established prior to the study? Yes, that they had written in detailed plan. Did the review authors explain the selection of the study design for inclusion in the review? That also they have discussed in detail. Did the review author use a comprehensive literature search? Yes, they have used all possible methods to include to do the comprehensive literature search. Did the review author perform study selection in duplicate? Yes, that was deduplication was effectively done. Did the review author perform data extraction in a duplicate? Yes, that was done. Did the review author provide a list of excluded studies and justify the exclusion? So Prisma diagram, they have shown the number of excluded texts, but no detailed table of excluded study or specific justification in supplements were given. So it's a partial yes. This category, usually other categories are yes or no answer, but this category has got 3 criteria. Yes, partial yes, and no criteria. So while Prisma flowchart does help understanding the methodology, but absence of excluded study justification limits auditability and transparency. Did the review author describes the included studies in adequate details? Yes, that was explained in detail. And if we see the supplement, they have given full details. Did the review author report on the source of funding for the studies included in the review? No, they have just disclosed about the funding of the current systemic review and meta-analysis, but other studies they have not given. These are non-critical step, but this is a no for the study. If meta-analysis was performed, did the review author use appropriate method for statistical combination of results? Yes, that already we have discussed in detail. If the meta-analysis was performed, did the review author assess the potential impact of risk of bias in individual studies on the result of meta-analysis or the other evidence synthesis? So here, high risk of bias studies were included. No meta-regression or subgroup analysis based on risk of bias categories were done. So this answer is a no. Though it's a non-critical matter, but we have got two non-critical domain no. Did the review author account for risk of bias in individual studies when interpreting or discussing the results of review? Yes, they have rerun the key meta-analysis, excluding the one trial with some concerns of bias. They have pulled estimate for risk severity score at 4 hours, shifted from -3.1 to -2.9, and the length of stay from -3.18 to -3.12, while heterogeneity remaining or nearly equal to 0. So this is a critical step, and it is yes. Did the review author provide a satisfactory explanation for and discussion of any heterogeneity observed in the review? That they have extensively discussed I-square and tau square they have given for each value, so they have discussed in detail. If the performed quantitative synthesis, did the review author carry out an adequate investigation of publication of bias and discuss its likely impact on the result of review? Here, publication of bias has not been published. There is no funnel plot, but if the studies, less than 10 studies are included, there is high risk of false interpretation. So if they don't, that is just a methodological gap, but does not bring down the quality of evidence. So these are yes. Did the review author report any potential source of conflict of interest, including any funding they received for conducting the review? That has been discussed in detail. So if we conclude M-star grading, question 7 has partial yes, question 10 has no, question 12 has no. So this review is methodologically sound and moderate confidence in findings. So takeaways would be OCS modestly reduces the V severity score in preschool children, greater benefit in those with recurrent Vs and asthmaized way, minimal to no benefit in first-time visa or mild cases, potential for vomiting as a side effect. IPD meta-analysis supports stratified rather than universal treatment. Thank you.
Dr. Anita Patel. That was quite an extensive analysis. There are a few questions in the chat box, and then we will take those questions and we will have Dr. Matthew's input on this, on the article that you have reviewed. What was the definition of preschool Vs is one question which was asked.
So preschool Vs is less than 5 years, what they have defined. So they have used the terminology preschool, but in their definition, they have defined the age group very categorically, that from 12 years to 12 months to 71 months. So that is that definition. What was the basis of selection of V severity score at 4 hours? So what they have done is they have taken a review of 253 board certified pediatrician. From that, they have made a consensus, and from that, they have taken two criteria. This was based on the pharmacological principle of prednisolone. On that basis, they have taken a V severity score at 4 hours. So if we read the article in detail, we'll get all the details. Did they grade the severity of V's at presentation? Of course, yes. That is why they could do the severity analysis. Did the differentiate?
Dr. Indu, can I ask a question now?
Yes, please, you can.
Yes, Dr. Patel, have you included all children with a virus-induced V's and a multi-trigger V's in this study? All children were included.
Yes, sir. So
both virus-induced V's and a multi-trigger V's?
Sir. Yes, sir. But all studies, they didn't get the data of viral PCR or viral isolates, and some studies.
But clinically virus infection, clinically virus infection, not by.
This is a study, so they have pre-formed question. If that is answered, the answer will be yes. Otherwise, they will say no. So there is no heterogeneity in this analysis. So they have formed a pre-formed question. In that, if they get a virus based on the viral isolate, then only they will say it's a viral infection. Like that, they have used. It's not that okay, if I feel it's a viral infection. They have not used like that.
Okay.
Okay.
One more thing that I wanted to ask you here is like they have looked at their short-term outcomes was in 4 hours, the early impact of using steroids on the patients. But don't you think that when they use a data like this, there could be it could be a mixed bag, as Dr. Sukumaran is saying. There's multi-trigger these, and those children could respond much better than what it could be in viral triggered Vs, and therefore their analysis or the data could be skewed on towards efficacy within 4 hours, because some patients will respond, the viral triggered Vs will not respond. So could the data be
So, ma'am,
not?
that is the whole question we are trying to answer, whether this will help or not in a broad category without doing any subgroup analysis. That is what this study is trying to answer. So they
Yeah,
have got
but
a
could they
statistically
did
significant.
not segregate the two groups to understand?
No, ma'am, they did sub-analysis. This was their primary outcome, but when they did subgroup analysis, when they did a post hoc analysis, in that they have seen family history of V's or atopy versus non-history. Then they have used the severity classification as well. That they have done. So,
Dr. Patel,
yes,
they might have gone for a family history of atopy and also
yes,
a
sir.
personal history of atopy, like
Yes,
atopic
sir.
dermatitis, allergic rhinitis. This group of children may respond very quickly to steroids.
Correct, sir. That is their finding, sir.
Yeah.
Okay.
That is their
I think
finding also.
I
Subgroup
think
analysis,
Dr.
they have found out.
Joseph, yeah, Dr. Joseph has got a lot of inputs for you. Dr. Joseph, over to you. Would you like to?
Thank you, madam. Thank you, Dr. Patel. Now,
Yes,
to
sir.
understand this meta-analysis a little bit, we need to go through these 5 things which I am asking. So, Dr. Patel, would you like to comment on these? These are in the chat box. What is the ranges
sir.
of the scores, PRAM, RSS, and Wood?
Yes, sir. So if I show you my presentation, I have given in detail about the PRAM score and all these things. One second.
It's okay. You can just tell us as it is.
Yes, sir. So this is the detail about the PRAM score. Scale is 0 to 12. These are the 5 components they have used. Pulmonary score, they have used 0 to 9 components. Respiratory symptom score, they have used 0 to 12. And that has got 4 values.
All right. And
Yes,
the half-life of oral prednisolone is how much according to you? Pharmacologically speaking, if a dose of
Yes, sir.
prednisolone is administered at time 0, in how
Yes,
much
sir.
time we'll see the peak action and how much time we'll see the action disappearing?
So peak will be half an hour to 2 hours and disappear by 6 hours, maximum 6 hours.
And if that is the case, any idea why in bronchial asthma we treat it for 5 days? The reason I'm asking, these things are all very important to make sense out of this paper. Some baseline information we have to have. You know, in acute asthma or acute exacerbations, the
Yes, sir.
oral steroid therapy goes for 5 to 7 days. Correct?
Yes, sir.
So if a treatment is such that its peak action comes within 2 hours and the effect disappears within 6 hours, why give it for 5 days?
But then, sir, we'll give you the second dose also. Twice daily we'll give.
Exactly. Why? If we are getting all the improvements that we need within
Then we
6
have to reach the
hours.
steady state concentration. That will reach by 3rd or 5th out this thing half-life, sir.
And does that tell you anything about the way the study has been designed? Their choice of the 4-hour thing.
Yes, sir.
So are you able to comment on that, whether it is appropriate?
Yes, sir. So they have clearly specified why they have taken 4 hours and 12 hours. So on the
That's
page
fine.
number
But
446,
do you concur with their explanation? Are you satisfied with that or not?
No, I am not satisfied, but I have to tell
satisfied.
what is written in the study, sir.
All
So
right.
that is why they have taken.
And last thing, what are the criteria used in each study for discharging a child from hospital?
So that detail I couldn't get, because in supplement also they have, so individual data they have not given in detail. They have just mentioned the subgroups. That details there, it's not available in supplement as well.
Now, if you think about these 5 things which I'm asking, would you
Yes, sir,
like
I'll
to
just give
interpret
one
this
second.
whole study in the light of what I've just said and revise your conclusion? Or would you like to stick with the conclusion which the authors have given? I'm just asking to stimulate you to think, because the
Yes, sir.
readers also will be. Yeah.
Sir, my only conclusion would be, I have, see, one second, I'll again show it. Sorry.
It's okay. No need to show. Even if you just describe it as it is, it's fine.
So if we go by first thing, with severity score at 4, the change is very minimal. It is statistically significant, but change is very minimal. And in grade analysis, it's just a moderate grade. So it cannot be recommended for the guideline purposes, or it cannot be recommended for the clinical use purpose. Only thing which can be recommended is, so if we see the grade analysis, so if we use these steroids, and there will not be any change at wheezing score at 12 hours. That is a strong recommendation. So if we give steroids in preschool wheezer, or if we don't, there won't be any change. That can be a strong recommendation. Length of hospital stay is a strong recommendation, and then moderate to severe category is benefited. And if there is a past history of asthma or wheezing, that this four recommendations can be used for the guidelines, because it's a high quality evidence.
All right. So now let us summarize very quickly. I will ask everybody who's listening to ignore the last few comments which have been made because they are not accurate. Now, this is a very nice way of doing a systematic review. It is the ultimate that which we can hope for, wherein what is called individual participants' data is available. So you can get that raw data and reanalyze in whatever way you want. It is very rare to be able to do systematic reviews like this, because most study authors or trial authors do not share their individual data. And the reasons they don't share it is because A, sometimes the aggregate data which they have committed is really not going to be available from the individual data if it were reanalyzed. That's one. Second is people don't feel like sharing the data, so we don't get it. So here is a study or a systematic review wherein out of 12 included studies, 7 authors apparently gave their individual participants data, which is pretty good. 5 did not. But out of these 7, the primary outcome for whatever they have reason they have chosen as 4 hours was available only from 2 studies.
Correct.
So if we look at figure 1 and figure 2, not is it 1 and 2 or is it 2 and 3, the big forest plots, the problem there is that the entire result at 4 hours is being driven by one subgroup of participants who had this so-called moderate to severe disease. Now, unfortunately, the scales used in these studies are not the same. So which is why I was trying to harp upon that point. 2 scale scores range from 0 to 12. And in PRAM, we know 8 and above is severe, 4 to 8 is moderate, so on and so forth. For RSS, we don't know if it behaves in the same way. And for the other scale, which is 0 to 9, again, we do not know. What we are seeing is that in both the groups, placebo as well as steroid group, there was a decline in the scale, whatever scale was used. But the decline was actually clinically of no significance, because in one group with the steroids, the score declined by 1.9 points. In another group, it declined by 1.6 points, which is pretty much the same, because 1.6 also will get rounded off to 2, and 1.9 will also get rounded off to 2. So on average, for an individual child, within 4 hours, even with placebo, the PRAM or whatever scale they've used has fallen down by 2 points, suggesting that the benefit is probably driven by whatever other therapies they were giving. This supposition or this view is strengthened by the fact that at 12 hours, anyway, there was no statistically significant difference as well. Now, why are we seeing some statistically significant differences, but no clinically meaningful differences? 2 reasons are there for this. One is when the sample sizes are large, even small clinically non-significant differences can achieve statistical significance. That is one reason that is very well known. Second is when you have multiple analysis, and here they have multiple, each forest plot has got 20 plus analysis. The dictum is for every 20 analysis you do, one will turn out to be statistically significant purely by chance. And if you look at the tables of figures 2 and 3, you'll see that pretty much this is what is happening. For each of those tables, especially figure 2, there is only one statistically significant result, and that is coming from the moderate to severe thing. Then you look at the fact that the benefit is seen in children with asthma. So if children have got a prior history of asthma, it really doesn't make sense to expose them to placebo, because the standard of care in an acute episode of asthma who's come with wheezing, who does not respond to the usual inhaled steroid therapy or inhaled bronchodilator therapy within the first hour, it's a standard of care to give parenteral steroids, whether you give it IV or you give it oral. So withholding that and then showing that steroid works better than placebo is like revisiting the trials which were done in 80s and 90s, based on which only steroids were introduced for children with asthma. So that's an important point to remember. Third thing is, if you look at the other outcomes, the length of hospitalization again has shown a beautiful statistically significant effect. But we can't interpret it. The reason we can't interpret it is, A, we don't know the time at which people were supposed to be discharged, and we don't know the criteria of making discharge. So in some settings, the criteria for discharge are when the respiratory rate normalizes, oxygen comes off, blah, blah, blah. So in each of these 7 included trials, the table of baseline features does not show the criteria for discharge. And so therefore, we have no way to know whether the discharge criteria were appropriate or not. Secondly, the duration which is showing as statistically significant is actually 3.2 hours. So that means 3 hours and 10 minutes. So that is again not a clinically meaningful this. So what it shows is basically, as the authors have done an excellent meta-analysis and everything, the only place where we differ with them is the interpretation of their conclusion. Their conclusions are all right, that there is a statistically significant benefit in the WSS at 4 hours, none at 12 hours. There is some 3-hour benefit in the length of hospitalization, no benefit in any of the other criteria. So as Dr. Patel has correctly said, these things go to suggest to us that there is no grounds for us to use the data from this particular study for the clinical practice that you and I are interested in. With that, I will stop. And then as the chat starts and the questions come up, then we will revisit if there are any questions.
Dr. Sukumaran, can we have some comments from you? You are our session expert this
Okay. Thank you, Dr. Indu. I first congratulate Dr. Patel for the excellent presentation of this Journal Club. It was really excellent, and he has analyzed the data very well, and he has interpreted the data in a best way. So again, hearty congratulations. And I thank the organizers for giving me this opportunity to be with Dr. Indu, Dr. Joseph L. Matthew, and all this. Thank you.
Any other comments? I think Dr. Joseph, you have given a really great perspective to the whole article, analyzing the limitations and how the article has been and the good point, the strengths of the individual data of each patient, which is very rare to find in most of these studies. So I think you've analyzed it very well. Any comments? Or I would hand over to Dr. Anil Sachdev for his comments.
Good evening, everyone. Thank you very much for giving opportunity to Gangaram Hospital for the presentation today evening. And thanks, Dr. Patel, for excellent presentation. And whatever I had suggested to you, you have incorporated those suggestions and made your presentation. The reason for selecting this article was that when we got the message from Dr. Indu and Dr. Ajay that we have to make the presentation on 16th of July, I searched and Dr. Patel also searched for the RCTs. You know, that is a typical studies that we present during the journal clubs. But after 22, we realized that there were no good RCTs published in the reputed journals. So then, when we were looking for, then came across this meta-analysis and just a quick review, and looking at the authorship and the gist of the meta-analysis. So I sent message to Dr. Indu that can we present meta-analysis. So she said, yeah, you can go ahead with that, and we started preparing it. Some good points about it is there are multiple authors in this, and some are from UK, one from USA, Finland, Australia. So there are different set of people, different minds, people who worked on this meta-analysis. And of course, the methodology is with the use of individual participant data is quite strong, and that makes the study quite transparent. And with the robust statistical methods they have used, they have given some results. Though the clinical implications, as Dr. Joseph has mentioned, 3 hours difference on the length of stay doesn't have a clinical the clinical mean. But yes, there is some guideline. But what I'm taking understanding from the study is that patients with the moderate to severe first-time visas, one should consider the use of steroids. That is my inclusion in the practice. I think that is my take-home message from this study. Yeah, thank you very much.
Any other comments from anybody? Dr. Rawat, Dr. Ajay Kumar.
Ma'am, my question is to Dr. Joseph, sir. Gina recommend steroid in such cases in the emergency room. Then when patient comes to visit moderate to severe asthma, Gina recommend. But sir, it said that we cannot follow this article interpretation. The article is saying the same thing. Sir Joseph, sir.
No, this is well known for acute asthma. Steroids
that's
is
your
the
point.
standard of care. So
sir.
this article is saying the same thing. And in fact, the whole paper's conclusion is being driven because they've got some asthmatic children in there. If you take out the asthmatic children from this, then you'll see that the analysis is not showing any benefit of steroid. So the reason that some benefit is there is because of those asthmatic children. And asthmatic children ko to nobody treats with placebo.
Yes.
So it would make no sense. No?
The mixed bag of preschool visas. So only as he said, only the asthmatic will probably show a positive response, and the rest will not.
And
So
only asthmatics are showing, because if you look at the data now, if you look at figure 2, now where is this here? It shows at the bottom baseline wheezing severity. So for severe wheezing, the numbers were very small. But if they looked at moderate to severe wheezing, so out of 173 plus 152, which is about 375 children, 325 children, that is the only subgroup in which there is some benefit effect seen from this particular thing at 4 hours. And then if you look at the 12-hour data, then you find it in the bottom here. The difference is only again in the moderate to severe group, wherein there are almost 700 plus children, and that is where some benefit is seen. Otherwise, there is nothing at all in the length of stay as well as in the thing. So this is the point in this particular thing. But methods are good. They've done it very correctly. And only thing is interpretation from these studies we have to make our own, not be led or carried away by what the authors are trying to tell us.
Sure.
Okay, there are
Dr.
some
Rawat?
questions in the chat. No. Okay.
No, most of it has been answered. Dr. Rawat, would you like to make any comment?
Yes, thank you very much, Dr. Patel. You have done a very good job of presenting a very complex study in a very simple manner. And I think what message we have got from Dr. Joseph is that this is a new method of meta-analysis where individual patient data is extracted from the studies and it is analyzed. So probably this is the first time we are reviewing such a study where normally we are used to studies. The meta-analysis is done by studies taken as a whole and not individually assessed. So I think this is a new thing which we have learned this particular time. And then second, what the view of Dr. Joseph is that in spite of a very statistically significant result or where forest plot is showing that it is statistically significant, that data might not be actually useful for clinical result because it has to be more closely seen and there could be serious flaw, like for example what Joseph has said, that this particular study we cannot directly take this interpretation that we can use steroid for all moderate to severe preschool visa. So I think in spite of study being done in a proper manner with very little methodological flaws and all parameters are to the point, but still there could be some flaws, and I think a master like Dr. Joseph only can help us to find out all these issues, and we are really thankful to him to tell us that these are the ways in which the studies should be looked and look closely and use this data for our clinical use. I think the session has been very well, and thank you very much to Dr. Joseph, Dr. Dr. Ajay, Dr. Antar Patel, Dr. Sajdev, Dr. Susimaran. Thank you very much.
Thank you very much.
Thank you, sir.
Thank
you,
you
sir.
very much.
Thank you.
Ma'am, one question is there. One
Yeah,
question. In case of acute headache, methylprednisolone injection, solomedrol use, please give your opinion.
So, I think if the patient, all steroids are equivalent, most studies are done on prednisolone. If the patient cannot take orally, then maybe you could use methylprednisolone. But I think whether you use most of these steroids are equivalent in an acute exacerbation of asthma, as far as whatever I have read.
Prednisolone is in fashion these days, no? That is why
Yes, it's
everyone
just a
knows.
fashion. So even
It's a fashion.
deflazacort is a fashion, but most data is on prednisolone. And there
Yeah.
is some data in up to date. Now they use dexamethasone for a little longer acting effect. So in an acute exacerbation, dexamethasone in the dose of
Yes.
0.2 to 0.5 milligram in a OD dose has been used for acute exacerbation of asthma. So that has come as a newer recommendation which I read recently.
Dr. Indu, that's what we were using during our training time.
Yes. So the world goes a round circle and it just kind of comes back. That's how it happens.
That's what we were using in our training time.
So I have been using dexamethasone for some time now post this recommendation. And the results are good because you just manage to give 1 or 2 doses and then you can stop the steroid. You need not really continue it. But that way it is good.
Yeah.
All right. If we are
Okay.
done for the day, if there are no more questions, then we can call it a day.
Thank you.
Thank you. Good night, everyone.
Thank you. Good night.
Bye bye.
Good night,
Good night.
ma'am.
Bye.
Good night,
Bye.
sir.
Good
Good
night.
night,
Bye
sir.
bye.
Good.